Today we have someone on that I'm very fascinated with. I was reading a few things about on her website, and I thought that's really an amazing way of looking at healthcare because, if you've been following my podcasts, I'm a chiropractor, but I'm fascinated with how the mind controls the body and the body looks into the mind and the fact we ever separated them. What a big mistake that was thousands of yeah, maybe 1,000 years ago. I'm not even sure. I've tried to get an answer to that because I know in Chinese medicine, they never really separated them. And in Western medicine, they did. And from my understanding, had a lot to do with the church and religious figures wanting sort of the mind and the spirit. And the scientists was allowed to have the body. And they just said, well, you get that, we get this. And in that, they went different directions. And of course, with some advents of, more modern psychology, maybe say Sigmund Freud, I don't know if that's considered modern or not, but some of the work he's done, we sort of started bridging gaps a little bit. And then in my work, I've always been fascinated with the idea that if somebody blushes, it's because they're embarrassed. So they have an emotion and they automatically have a skin color change, right? Their blood vessels in their cheeks and maybe their whole face dilate and their face turns red. So if you don't think that your emotions are affecting your body, or you may think it does, but you don't realize how deeply that's happening, take a look at that. That's something obvious on the outside of the body. What about your liver and kidneys and intestine? All the other parts of your body that may or may not be turned on, turned off, regulated differently with the uptake of different hormones, things like cortisol, a lot of us know about stress-related hormones. But today we have on the show Kelsey Bennett. She is a clinical social work therapist and recently a doctor of that. So this is really exciting. She's building her career and building her knowledge base. And she's on the show today. Welcome, Kelsey. How are you?
I'm great. Thank you so much for having me.
Yeah, my pleasure. Like I said earlier, I looked at your website, some of the things you had to say. One of the things that got to me, and I've told many people this, I had a patient that had a tattoo in, I think it was in Chinese writing, and it said something, and I'm like, what does that mean? And she said, there's beauty in the broken. And I thought, I don't have any tattoos. I'm not really from that, sort of era. And I thought, but if I got one, I think I might say something like that because it's always fascinating to me when somebody appears to be kind of perfect, they kind of bore me. And when someone has different things about them that are odd, I've always thought that was more interesting. So tell us a little bit about some of the reasons you got into what you do. I got into what I do because of migraine headaches. I was off to do very mechanical things. I always loved cars and fixing things and got terrible headaches, went to a chiropractor, got amazing results and thought, wow, it's a hands-on job fixing the frame of a body and affecting the neurology of the body. And that was enough to draw me in. What drew you into what you do?
So very similar to I think I was on a different path. I went into my undergrad wanting to be a neurosurgeon. So I've always loved the brain. My aunt, she was a PT in the area, Dr. Susan Bennett. She kind of got me very interested in the brain early on. So that was originally the path I wanted to go through. But then some stuff happened in my life. And I was like, I don't know how to deal with this. This is not concrete, right? This is not black and white. And I ended up kind of moving into more of the field of psychology to figure it out. And I ended up meeting a great therapist as well, who kind of really helped me see the world totally different. And so with that kind of interest in the neurophysiology as well as psychology, I did start into behavioral neuroscience. So I was going to do some research in behavioral neuroscience. I was interested in kind of that blend of the two. However, one day when I was sitting at the lab bench, one of the other students came and sat kind of next to me and just started like telling me about all the problems. And I was like, man, I wish there was a job where I could just listen to people and help them through their problems. And I was like, oh, there is a job like
There
that.
is.
Yeah, I ended up going into changing and going to my master's in social work, and then ended up going for my doctorate as well.
That's fantastic. Well, I think it's fun to discover your gifts and your interests early in life. Some people struggle in that arena. Some people, they're just sort of born, pop out and say, yeah, I know what I want to do. I had two friends of mine that were like that, and the rest of my friends are more like me that were kind of open to a lot of different career choices. And then, what are you really passionate about? What do you want to do? I like fixing broken stuff. I always have. The first new car I bought, I was disappointed because I couldn't really fix it or make it better. It was already brand new and good. It's kind of a strange feeling. So in my practice, when someone comes in and says, I have a problem, it's exciting to me. It's like, all right, you got a problem. This is what I do, right? And you sound like you kind of work the same way. One of the things that always fascinated me was when I first studied Freud's work. I thought, wow, this is incredibly bizarre. Some of the different, the id, ego, superego, self-esteem, depression. He has so many big words that we use every day. And I think a lot of people don't realize that they came from Freud. He invented those words. And there's sort of a rejection of Freud in a lot of ways and in more modern thinking, maybe because he's kind of dark and what he focused on was pretty negative and people don't want to really dig into that because some of that's maybe just evolutionarily accurate and it's just how it goes. But I never like to throw out any one entire person just because they've made a couple of mistakes or we've researched or evolved beyond their work. I'm curious as to your opinion when you look at his work, and I think anybody has to study his work if you're going to get into the mind, because in my opinion, I think he's extremely important. But let's keep going. I don't think the founder of chiropractic studied one technique and was amazing at it, and sooner or later passed away. And people took what he did and kept going. And you can go too far. You can find a technique that's absolute garbage. But there's so many techniques that are amazing in chiropractic, and they grew out of his fundamental work. Do you think that a lot of stuff grows out of the fundamental work of Freud? And in your work, what do you think of his work?
So I definitely agree with you in terms of what you're saying about it's a foundational piece. And I do think a lot of what, especially in I kind of like his earlier work better. You were mentioning earlier about like the disconnect between the mind and the body. And he was one of the people who was kind of believing that some of these things might originate in the mind versus the brain. So he did kind of separate those two, but I appreciate his perspective on the fact that it's not like a biological thing that might be like wrong. It's something that we have learned, adapted, constructed, and let's look at that a little bit differently. So I definitely appreciate that. And you mentioned the id, ego, superego, 100%. That is something that I think grew into. It's actually an intervention that's becoming much more popular recently, and I absolutely understand why. I have implemented it in my practice as well, and that's internal family systems work by Richard Schwartz. So this is the idea that there are different kind of parts of the self, and some that are, protector parts, some that are more exile parts that hold a lot of, trauma and maybe some of the dark stuff that you were talking about earlier that would not allow us to function in everyday society if it was always present, right? So necessarily our brain needed to protect us and push those things out of the picture so that we could survive. As I'm sure the body, the brain, it adapts to help us survive and keep going. And it doesn't always register when, we're safe. So I think that kind of was built on some of his work over time. And there's also the concept that I implement and I share with all my patients. I'm big on psychoeducation and making sure my patients understand what I'm doing, why we're doing it. And I'm sure there's some people that don't care as much. A lot of the people who work with me, they're the kind of people who do really want to understand. So those are kind of my best fit patients. But it's the idea of structural dissociation. So that's the idea that within your psyche, there are different ego states. So not necessarily just the id, ego, superego, but these different parts of ourselves or parts of our psyche that might be more or less integrated. And if you can see the mind kind of on a bit of a, not separated as much as maybe sometimes the DSM has it be, but more on kind of a gray scale, you can see the levels of maybe structural dissociation within one's mind that might, for example, PTSD, that's you're switching from one state into another and then back, right? There's one kind of big separation where the trauma is held here and you're here. And maybe a little bit further where you're into complex trauma, which is where I primarily work. My population suffers from complex trauma. So I'm kind of in that secondary dissociation, it's called. And that's where other things might be. You know, if someone has borderline personality disorder or some other, I hate the word disorder, but we'll use it here for the sake of simplicity, disorder where there's a lot of, switching of emotional states quickly, or there's just seems to be a separation between the sense of self. I like to see it more on that scale. And I think, we can pull back to Freud on a little bit of that as well, where he started with some of those topics. And the defense mechanisms as well. We can see that in some of those protector parts. But yeah, I would say a lot has been built on since then, but I'm glad that he did the work that he did.
You mentioned complex trauma. You said most of your clients have complex trauma. Define that real quickly for me. How does it differ from non-complex, let's say?
Love that question. So simple PTSD is kind of, you had one instant, or it was one particular, thing that really led you to have a trigger. So you might like have a car accident, right? And so now you're driving your car, that is your trigger, and you might, have some symptoms associated with that. Complex trauma is more prolonged, sustained trauma over time. So a lot of this, we're looking at relational trauma early on in life or narcissistic abuse later on. So it's more insidious, and it has 6 symptom clusters versus just the 3 with PTSD. And it's not in the DSM. It's in the ICD, which the rest of the world uses, but it's not in the DSM. So that is part of what I want to hopefully help integrate into the DSM also, and say like, hey, there is a big difference between these 2 conditions, even though they just released the DSM-TR, and I don't love their explanations as to why complex trauma is not in there. But I understand for now that it's something that practitioners hopefully will keep advocating for.
Yeah, I can imagine that's interesting, because I have worked with patients that I guess would fall into that complex trauma. There's so many things that have gone wrong in their lives for so long. It's layers of dysfunction and abuse versus the person who has one massive thing that, and usually I find the person that has the one massive thing, whether it's physical or emotional or the mix, it's so much simpler, because even if it's gigantic, the rest of their life has been pretty functional. So they have sort of a decent foundation usually, unless it happens super early, obviously. And they can draw from that stability that they once had, even though they went through something horrifying. Where the other individual, appeared to never have a nice foundation to be able to rely on. And so they're really just, disjointed on many levels. I have patients that have, lower back problems and pelvic issues, and a lot of it comes from sexual abuse. And I have to approach that topic pretty gently, obviously, because, I want to be, one of my favorite sayings to get out of jail, you got to know you're in jail, right? So I like to tell people, here's the prison you've found yourself in. And some of that is this. And so often I know the toughest word, and one of the things I try to get patients to do to let go of their physical tension, is forgiveness. And it's, I've almost been kicked in the teeth for, mentioning that to patients, because they really aren't ready to forgive, because they don't think that's part of the game. They don't think that's acceptable. They still want to dig in and be miserable, and, continue to have some kind of harsh relationship with the individual, if it's a person, let's say, that has wronged them. And I try to get across that. I think as a chiropractor, whether you realize that or not, I think I share a lot in common with psychologists, bartenders, and hairdressers, I always say, right? Because I'm with a patient for an amount of time, and we start talking about life and our problems. I'm pretty personal with my patients. They know I don't really hide much from them. I just can't do it any other way. This idea of a professional boundary, certainly in certain areas, I draw a very sharp line there. But when it comes to my personal life, like my children and my workout schedule and my, physical ailments and problems, I share them openly, because this is a person I'm talking to, and I find it difficult to be this detached, clinician. I can't operate that way as successfully. So I guess I risk a little bit of people knowing more about me than maybe they should. It has never been a problem, so I just keep rolling that way. But I think it's I appreciate your definition of the two, because I never thought about just saying complex or non-complex. I just thought, well, this person's got a load of stuff and this person has one big problem, but it's nice that somebody's defining that and working with it. So you take on the hard work. In other words, if you do complex trauma, you said that's most of your clients are that way.
Yeah, I'm very similar to you. The more complex, the more I am ready to like get into it. I love that work. Well, of course, I'm happy to see people with, anxiety, but, I can do that. It's just, a couple weeks then, okay. I really like to dig in, and when I do initial consultations with people so they know it's a good fit before we, commit to this. And I tell them, like, if you want, we can always just do the coping skills stuff and then you can decide if you want to continue. But typically, we're going to dig in and get to the root of the problem and, go in there and pull it out. And it's going to be tough. And I tell them too, I will work just as hard as you do. So I'm here with you in it and I respect what they're doing. So.
Yeah, it's great when someone works as hard as you do and you work as hard as they do. Everyone has patients that you're working harder than they are. And a lot of times they're the first one to bring it up. I'm usually a little more passionate about people getting healthy than they are. And unless they're in extreme pain, then of course that'll supersede. Their passion for being out of pain is better than mine. But if I have a patient that says, oh, I just got diagnosed with diabetes, you're a natural health guy, what do you think of that? I'm thinking, I think a lot about that because it's in my gene pool, but I'm doing great, but I do a lot to be great at that. I know that's probably a genetic weakness. So I take that head on. So here's all my 55 ideas. If you can stand to listen to it and put up with what I'm about to tell you, it's not going to be a little bit of work, right? But hey, that's the way it goes. In one of the things also in therapy, I remember studying, I think it was Jung, and he had said, it was client-centered therapy, I think it was called, right? Versus Freud's approach. And that he just repeated back to people. I remember laughing when I was studying it. I love my psych classes. And this one was, he repeated back to people, and clean this up for me. I'm just going to give it to you how I know it. He repeated back to people what they said and let them do most of the talking. Mm-hmm. And, I'm a pretty chatty person. So for me, I got to learn to stop talking a lot in my consultations with patients and my interactions and treatments with patients. And I know that, and I think I've mastered that, I hope. So in your therapeutic sessions, how much are you listening and how much are you talking?
I'm going to say this a lot. It depends on the patient. I actually am opposite of you. I find myself with a natural proclivity to kind of be more observational and listen first, more. So I have to sometimes, and there's a concept called attunement. So you attune with the patient kind of to see where they're at. And if you are in a good, and this is why therapist self-care is so important, right? If you are able to connect with your emotions, then you can kind of be centered and then be there with them a little bit better and kind of figure out where they're at, what they need, what they're thinking. And if you can get to that space, you can really figure out, okay, am I needing to talk a little more, listen a little more, guide a little more, shift my, tone, body language a little bit more. And so I do have patients who they are so used to not subjugating, so pushing their needs aside, not stating what they need to avoid some sort of consequence, whether it's abandonment or rejection or, anything. That they have not had a lot of practice putting their thoughts, feelings into words, and just doing so elicits anxiety. So sometimes I will start by, naming things and saying things that they might be wanting to say, kind of figure out, and they're like, yes, that's it, or no, that's not it. And that will kind of help to evoke the conversation. And over time, they'll get better. And I just need to then step back and give them space to find the words a little bit better. And over time, we get to have much better dialogue because of that kind of back and forth. So it really starts with that attunement process of figuring out where they're at. And that's where, the Jungian person-centered, you start where the client is at. You don't start where you want to be. It's okay, let me get down here with you so that, we can kind of see the outcome together, but I got to start where you are.
Yeah, that's absolutely the way to go. I do that in my sessions as well with patients. I have people that just want to tell me what's going on. And I think, okay, it's all ears now. And I just stop talking and I let them go. And you can see the relief they have by the end. You know, I remember one time a patient said, "I can't believe how much time you spent with me." And I really didn't spend that much time, but the time I spent was me not talking. So they were able to get the story out. The time I have to intercede, and you probably have to do the same thing, is to, you know, get people to talk about the important things and get them off of tangents that might not be, you know, that valuable to the therapeutic session. You know, I do my best with that.
That is harder.
Yeah, yeah. One of the biggest questions I want to ask you, and I have a book called Healers on Healing. And if you've never read it, it's really cool. It's taken each healer. Have you read that by any chance?
I haven't, no, but
It's been around a while. It's a really cool book. It's taken the sort of the head clinician or doctor or practitioner of any of the big healing techniques out there, like the most fundamental and biggest people in chiropractic, and in every profession in the day. It was probably written maybe 20 years ago. And it's great though, because they basically ask them the same question, you know, what makes people heal? What gets people to heal? What encourages people to heal? What's the thing? And each of them go into either a philosophical or a very almost mathematical clinical explanation of what it takes to get somebody to go from, you know, someone who's, you know, healing or not. I'm going to ask you that same question. Like, what does it take to get someone to heal? I know it's a massive open-ended question, but it gives you a long leeway to say what you want to say. So when you look at somebody, you think, okay, how do I get this person to heal?
So first step is always, and I come from obviously the more trauma background, but first step is safety. They need to feel safe. And sometimes, you know, with trauma, I'm working with people who, through discussion, we come to discuss the idea that they may have never, ever actually felt safe in their life. And so they don't even know what that looks like. So first it's kind of defining that. And that's not just physical, it's emotional safety. And if you're familiar, excuse me, with Maslow's hierarchy, it's kind of Maslow's hierarchy needs. So you got the physiological, you know, needs at the bottom, and then after that, safety. And I, you know, pull that out and I share it with patients. And, you know, I'm like, we're here and we will get to the other steps, but we got to, you know, kind of scale it down and just make sure you feel safe. So part of that is defining it, creating it based on their definition, and then kind of going from there. And that is internal and external, and how to feel safe even in unsafe environments, and how to set boundaries and advocate, and you know, all these different skill sets to create safety. And you're not always going to have, you know, the optimal environment, but a big piece of that is developing trust, I think, with yourself, that no matter what, you are not going to, you know, subject yourself to persistent unsafe situations, because then that becomes a self-betrayal, and then you lose trust, and then you can't find the safety again.
I think of some people I know that do that. They put themselves in unsafe situations all the time. It's almost like they're addicted to their own adrenaline. Like they don't feel alive unless they're doing something kind of dangerous. And whether that be, you know, a physical act or putting themselves in an emotionally dangerous situation. I always found that fascinating, because it's like they really do need the opposite. You know, why are they continuing to go into these, I guess it's a pattern of unsafe behaviors? And, you know, but getting somebody to feel safe in a one-on-one consultation with you, I would think what comes to mind for me is that privacy would be, you know, if I think of myself, when do I feel safe? I love talking to people that I know are a vault. Right now, you're bound by clinical laws and regulations to, you know, keep what they say in that, unless there's very unusual circumstances. And so am I, doctor, you know, patient, doctor, client privilege type of thing. But in the regular world, you know, I have a few friends that are like vaults. You know, you tell them things and they're never telling anybody. And then there are people that I can't talk to. I can't tell them more private kind of things that I don't want advertised, because they can't do it. They're just gossipy or whatever. So I get what you're saying about that. I would think in a clinical setting, I would just have to believe that I would feel safe telling this person something personally. Yeah. So what's the next step after they feel safe? what do you have to do to get somebody to get the healing equation going?
So I think in general, the next step is kind of what you said, with your clients as well. Like people don't want to see, okay, what is actually going on here? Like what's the actual problem here? Because that's the thing they're most trying to avoid, right?
Mm-hmm. Mm-hmm.
So it's actually starting to move toward acceptance. And acceptance does not mean you like it. It doesn't mean you don't want to change it. It's just saying right now in this current moment, this is reality, right?
Mm-hmm.
Once we know where we're at, then we can get where we want to go. But if I'm pretending I'm somewhere else, then we're going to never get to where we actually want to be because we're not accepting where we're at, you know?
So truth, in a sense.
Yeah.
Right.
That takes, that takes time, and that takes uncovering things. And sometimes I have worked with patients, as I'm sure you do too, you notice patterns, you can kind of figure out after like 10 minutes, okay, this is probably what's going on, 15 layers. Getting buy-in, getting trust, getting there, if we use IFS language, protector parts to step aside to even get to a place where they can look at that, that's partly developing trust. And that is part of safety. You mentioned Vault, and I wonder if that's coming from Brené Brown's Braving Trust.
No, it's not.
Oh,
That sounds, I should probably read it though, because I love the term, but
yeah.
she got into the idea of a vault.
There's this idea of braving trust. So like what you need to develop trust in relationships. And I kind of keep that in the back of my mind whenever I'm trying to develop this trust with clients, so we can actually, move into some of that acceptance and like, hey, maybe this is actually what's going on. Off the top of my head, I'm struggling to remember all of them, but it's like boundaries, reliability, I think acknowledgement, vault being one of them, integrity. So these things that you need to have in relationships to really develop trust. And that's internal and external. That's, do you set boundaries with yourself, right? A lot of people have, and I apologize if I'm tangenting a little bit, but a lot of people don't have a good relationship with boundaries. And that tends to start when they're young, right? So are boundaries seen as a punishment, or are they seen as an act of love, right? So your parent stops you from running across the street and says, hey, you can't do that, because they love you, right? But for some people, like they were developed in a very rigid household where, they put one toe out of line, they're punished for it. So that's seen as bad. Or in an environment where they had no boundaries, right? So now it feels like, how dare you say that to me? Absolutely not. And they might get defensive and perceive a boundary as criticism. So this idea of developing trust within the self and with other people as well.
Yeah, I find like part of when I trust somebody and they tell me something that is painful and true, for example, you really, I have a friend of mine that's just known for dishing out the truth, and he's quite comedic, thank God, but he can't hold back what he sees. And when the elephant's in the room, he's going to point it out. Yeah. And people really love that about him. And he has a special sort of gift and ability to actually do that. And I borrow that gift as much as I can from him. I have a little bit of it, but he has it all the way down to the core of him. But I really think it's so important that once I get somebody's trust, or I trust them or they trust me, to be able to be more truthful. I love someone that can take it. It's difficult when you get someone that's just, every time you try to tell them something truthful, because of their maybe complex trauma, they don't want to hear it, or they get mad at you. When someone tells me something uncomfortable, that I realize, wow, that's true, I kind of laugh inside. I have a decent sense of humor, thank God. And I'll think, yeah, I am doing that, and that's pretty ridiculous. And I'll try to clean it up. Because, and especially, and you always got to consider the source. Is this person trying to knock me down? Or you do it in front of a bunch of people? Is this what they constantly do? Or is this a person that's doing this out of some kind of compassion for you, because they're like, hey, this seems like a good guy, but somebody should tell him that, some of the stuff he's doing is, a little off base. That's, I try to do that with my patients. I try to say, my message to my patients is I absolutely love you. And I don't say that out loud in that way, but I want them to hear. I actually do say that to some people, but I can't say that to everybody. They can't handle it. But I want them to know that, and then be able to say, hey, here's what's going on with you, right? I have a patient, she's probably 350 pounds, and she keeps asking me why her knees hurt. And I've told her, well, there's a lot of weight bearing on your knees, and your knees are not designed for that. And she still seemed to not be hearing it. And I had to keep using further and further kind of cutting analogies to be able to get it down to what it really is. And then she finally you can see her nodding into some kind of like, all right, I guess I will hear that. I mean, she has to know that that's a major factor. It's not that complicated of an idea, but you can really tell there was an amount of denial. And then when I kept getting more and more cutting and more sort of plain truth with her, she let it go. And she said, okay, I get it, and it helped. So for me, it's love and then followed by truth. And because I think that it would make somebody feel safe if you really believe this person really cares for you and really wants the best for you, and then just telling you something painful, that's a bit of a balancing act. Do you find yourself in situations like that where you're about to say something like, hey, I got to drop a truth bomb on this person? Should I do it or shouldn't I, or how should I put it? How are you in that arena?
Yeah, I mean, I do that all the time.
Right.
And there's it was social work, and shout out to UB. They're wonderful with this. Really making sure everyone who goes to the program understands the principle of trauma-informed care. And I feel like that's a big part of, how many years at UB now for me? Like it's so in my practice. It's, trustworthiness. It's not being, I'm not sitting there as the expert. I'm, listening to you. I'm here with you. I'm collaboration, it's trustworthiness, reliability. So there's just these pieces where if you can make people see that, like, we're on the same team here. And I'm asking you, like, I think this is going on. What do you think? This is, I come to the table. What do you think? How do you feel about that? Maybe that, maybe this, like, let's chat about it. I'm not sitting here saying, this is what's happening, right? Because I couldn't in good conscience do that, but I come with a certain skill set and they come with a certain skill set, and we can collaborate on that. And I will say too, it's sometimes, especially with, complex trauma, there is a piece to people can't tolerate love, affection, kindness, right? It's like, nope, that's too much. I don't like that. So we might need to keep it more facts-based originally, develop that, but the tolerance for that. And there was something else you were saying about, I'm trying to remember now, creating some of that safety and dropping those truth bombs from a place of love. And I try to embody kind of like the transparency, which is another one of those principles, is if I can be totally comfortable in myself and transparent, just exactly what I'm thinking, what's going on, then that sets the stage hopefully to take like some of the onus off of everything. And they can take it or leave it, and I leave that with them. They can take it. I'm not forcing you to do anything here. You have choice about whether you want to pick this up or not, and that's fine.
Yeah, I mean, it sounds like you're showing some real humility in saying to somebody, this, what do you think of this? This is what I'm seeing. In other words, I am not telling you, I am not the word of God coming down saying, here's your problem, listen to me. You're like, here's what I'm seeing. And I like that because I do the same thing. Someone will say, well, why does my back hurt? And I said, but I think what I'm seeing is, or I think what's happening is, and I let them tell me, no, that's not happening. And I'm like, okay, cool. It just seems like it is. Well, why don't you think it is? And then they'll tell me, I'm thinking, oh, okay, well, that's why. And, I am wrong in that assumption, but I'm glad we brought it up. So then this is what's happening then. Most likely, if it's not that, it's got to be this. And instead of saying, I know what it is, I've been practicing forever and I know what I'm doing. I feel like saying that sometimes, but a lot of times the person then just tells me, well, here's what's happening. I'm like, okay, good. Now we know. right? So I try not to get confrontational ever with patients, but at the same time, people want to be led. Oftentimes, some people just want to talk about it. So, like we said earlier, how much talking, how much listening. I think that's with me, it's probably with practice and over time, I think I'm becoming better at realizing, okay, this person needs a lot of talking. I better, because they're not saying anything for one thing, or I need to dig out of them what's going on. I mean, I just see a difference in between male and female patients. To get a fact out of a 19-year-old boy about his back is digging and digging and nagging and pestering and asking the question 38 different ways. To get that same information out of a 75-year-old woman, not a problem. She just say hi, and then here you go. And then I'm wearing out my pen, writing down all those things she's telling me. And both of those are challenging. One is, how do I decipher what's important from somebody telling me mounds and mounds and mounds of data from the history of her life? And how do I get this person to tell me what's really going on? And I see that it's a male-female thing often. So I read somewhere that a woman speaks 7,000 more words a day than a man. And it's both. And then I'm not saying one is better than the other. One is a better idea than the other. Both of them have their place. And I have to get my patients mainly to tell me just the facts, ma'am, as they used to say, right? That kind of thing, because you want to be able to get to the crucial part and make the visit time worthy, right? In the time you have. Are your visits about an hour long? Is that classically how you work with patients?
Yeah, it's technically 55 minutes, but usually we go for the full hour. Just give myself some buffer time.
One of the things that a lot of people talk about is sort of coaching, life coaches and inspirational speakers, motivational speakers. Do you find yourself as a life coach? Would you put that category in? What do you think of that idea?
I do not see myself that way. I have a friend, colleague, Maureen Kemeny, which knows her as well. And she and I have talked about this, and life coaches are a bit more, from my understanding, don't dig into the past to kind of see, the ideology of some of these things and like process this stuff. It's more, okay, where do we go from here? So right. I do future planning type stuff, but it's more integrated into digging up and healing, the wounds, I guess, from the past. So no one is usually coming to me simply to say, okay, I want to figure out what I want to do as a career. I could be helpful with that, but that's not how I could best use my skill set. And I think a life coach would be better fit in that situation.
That makes sense. I would think that your training would be to break down what's gone wrong in the past, so then they can move forward with that knowledge and build their life. And a life coach is like, okay, let's set some goals and get you going in this direction. And I can see how both have value. But if you have enough stuff in your past, just going forward with a lot of dysfunctions, probably going to be a bumpy road. So I think someone has to clean it up. I agree. One of the things I have always had issues with is when people just blame their parents or their upbringing for everything. But at the same time, I battle with that, because I think to myself at the same time, okay, if you had some horrifying parents, you definitely are at a disadvantage. And, you can't just spend your life unforgiving and hateful, but at the same time, you definitely got a bad start. So how are you going to break this down? And do you get into once again, that Freudian idea that the mother is so important, and what do we do about her? Does that come up a lot? Are you drawn to that as a way of digging out the past?
Every single patient, I do a genogram, and we start at 0.
Did you say a denogram?
A genogram. So a genogram is
a genogram. Tell me about that.
Yeah, it's kind of like I describe it as more complicated family tree, but it starts with you and then all your history of relationships, romantic. Then we go up to your parents, siblings, parents, talk about the relationship, grandparents, if it's relevant, great grandparents, really close friendships or important friendships in your life. So, I start with that to get the full history. And in that, usually I see relational patterns. And how they persisted, how they changed. Sometimes those small t traumas will come up, and small t meaning, it's interesting what you said there. Horrific parents. Sometimes, most of the time, I would actually say, parents don't have to be horrific to have caused some stuff for patients that they deal with on a regular basis. So what I see a lot is parents who are simply emotionally unavailable. And so for that emotional deprivation schema, and I can talk more about schemas too if you'd like, it's kind of just the blueprint or like the lens through which you see yourself in the world. So it affects everything going forward, right? Because it's your lens. If you had a parent who just was really busy working all the time and they didn't have energy to notice when you were sad, then you learned, oh, okay, my feelings must not matter too much. And you just learn to like shove that stuff down. But over time, trauma and these emotions get stored in the body, right? And then you see certain physical stuff come up. So that's how that mind, I guess, body connection is really seen in my practice. There's a great book, you might have read it, called The Body Keeps the Score by Bessel van der Kolk. It can be kind of, so warning on that, but it's really how those things are stored and connected. And so, I think it's completely important with at least the patients I work with to start from ground zero and assess all of those relationships.
Yeah, that I like the way you do that, because you're breaking down each relationship and looking for important things that maybe failed the person or like created that lens.
Yeah,
and
exactly.
I think to get them to, so when a person puts together that a series of people that are important and have done certain things, how do you get a person to then say, okay, I was never, my parents were never emotionally available because they were too busy for me. I mean, how do you get that person to, how do you change that lens? I mean, is there a simple answer to that, or is that years of talk therapy and counseling?
So that's kind of I've and from mentors have learned and integrated, and part of my doctoral work was actually creating an integrated intervention to do that. Sorry, I didn't know if I got logged out for a second. I kind of have like
There you
a
are.
three.
Something got funny. You're good now.
Okay. And so I always start with the genogram to kind of figure out what's going on there. And then I'll give them, assess their schemas. So the schemas, I'll figure out, okay, what schemas were you set up for based on kind of how you were raised? Which ones do you have now? And then, okay, what created those? Let's talk about those. Why do you feel this way? What did you notice? Why did you score it that way? And sometimes, I know I've mentioned that emotional deprivation schema a lot. That's the one I see mostly misscored, because it's the trauma of what wasn't there. So people don't know what they didn't have, right?
Right.
So, they'll be telling me something and I'll know probably didn't get what they needed there. But as we're talking, I'll say, okay, well, did your parent, when you were sad, get down on one knee, look at you and say, okay, hey, what's going on? Talk to me about it, right? And they're like, well, no. I was like, okay, so maybe let's make this number a little bit higher, because that may be something that you should have. And then it's like, oh, got it. So then after we look at those schemas and identify what caused those blueprints or lenses, then typically if it's appropriate, I'll move into some of that IFS work. So these parts of you that might have separated off, those earlier parts that held all that sadness, or, from not having the need met or loneliness or whatever it might have been, they'll have, some protectors. And sometimes that's a part of you that has extremely high expectations for yourself. And, unless you've achieved 150%, you've failed, and then you beat yourself up. So that part, that inner critic, really likes to kind of keep you in line so that more vulnerable part doesn't come out. So we got to kind of get a dialogue and understanding of these parts and make sure that those parts that are exiled or, holding the trauma are in the room with us when we then move into EMDR, which is eye movement desensitization reprocessing. and it's a more efficient trauma treatment than, like prolonged exposure or anything like that. And it's a neurologically based treatment, where we kind of identify all these things that led to those schemas, and then we reprocess them. So kind of changing the way they're stored in the brain so that hopefully your schemas actually change, and therefore the way you interact with the world, in a lot of different ways change because the lenses have changed.
When you say schema, do you mean like sort of processing belief?
Yeah. So it's kind of like a set of beliefs about
Yeah.
yourself or the world.
Okay. Okay. I think it's with the amount of anxiety I see in the world right now, and I'm not saying just the pandemic related stuff, but it just seems to be growing and growing, this idea that people have anxiety. Is it something we're paying more attention to, or do you think it's something that's actually increasing? In the 1950s, did people theoretically have anxiety? Did they ignore it? Were they raised so differently? Was there less knowledge, so there's less tension? Do we know too much? You know, I mean, what is it that's causing? So I don't really get anxiety. It's not really how I'm wired up. So I'm fascinated by it. I'm surrounded by a lot of people that have anxiety. I think anxiety-ridden people are maybe drawn to me, which is nice. I find them interesting and actually quite stimulating to be around. But where is it going? Where is it all coming from? Why does everybody seem to have this, at least this diagnosis? How real is it? Talk to me about anxiety.
Well, I say anxiety is kind of just a normal part of, our humanity. It's there to say something, like all emotions. Emotions are information, right? We see them as like good or bad, but none of them are good, bad, this, that, right? They're just telling us something. So anxiety is there to say like, hey, might not want to be doing that, or there's something there you really need to be paying attention to, right? Sometimes it's got an important message and sometimes it's a little maladaptive, but the more we can listen to it, I think the better. I think it's probably a combination, and I can't say for sure. I think it's a combination probably of we are becoming more aware of it, and I'm so happy to see like this mental health is becoming more normalized in our society, and the stigma is starting to be reduced. So super happy about that. So there's probably a little bit of that, a little bit of things are technology has made things so insanely fast that, it's our physiology, I don't think has been, adapting, going, to all that stuff quite yet. And there's also, with smartphones, like a lot of the time I see there's no boundaries, right? So boundaries keep us safe. So if we are afraid that, if we put our phone down by 6 p.m. every day, that we're going to lose this business, right? Then we're not going to set that boundary, right? And, so there's that aspect of it. And then societally, I think there's a lot of different things we could go into discussion about how that has changed and expectations have changed. But I think it's really a combination of all those things.
Yeah, that makes sense. I mean, a lot of things I know, like all of a sudden, but 15 years ago, I was in practice and everything was carpal tunnel. Everybody that came in with a hand problem had carpal tunnel. And I was always telling people, well, no, carpal tunnel is a very specific diagnosis and very specific findings. I don't like to just throw that out there because it's billable. You have, cervicolitis, you have, de Quervain's disease. There's a whole bunch of conditions of the hand that are neurologically nasty things that aren't carpal tunnel, but it was sort of like a new diagnosis, a newer diagnosis. And I think with all the keyboard work everyone was doing at that point, we were getting more hand traumas, and some of them were carpal tunnel and some of them weren't. So the question was, is this really happening? Are we really destroying our hands, creating carpal tunnel, or how many times is it our neck, and do they relate? And sometimes it's both, and that kind of thing. But I think with anxiety, like you're saying, I come from I love evolutionary biology. I love anthropology, because to me, when you put those together, they answer great questions. And I've said this on my podcast before. Someone else asked me about alkaline water. How good's alkaline water? And at the time, this is probably maybe 8-10 years ago, I didn't know. So I said, I've heard of it. I'll get back to you. So I did a search on it, and I didn't read about alkaline water from like companies that make alkaline water. I said, does alkaline water exist in nature? So I Googled that and everything like that. And it turns out in very pristine environments, alkaline water is found. Great. So it's a certain mineral composition that alkalizes the water. And that must be real then. Then the question is, how much do you drink and that kind of stuff. You don't completely alkalize yourself and end up with some other terrible problem. So, but that's what I do as I look into nature. Are running marathons a good idea, Dr. Mike? Well, who runs 26 miles to run away from a bear or to catch a bear, if you're crazy enough, or to do anything? No, well, the answer to that is nobody in nature does that. The 26 miles came from the marathon to Athens, Greece, and then the guy died supposedly when he got there to deliver a message. So you're going to need really good sneakers and a lot of water and electrolytes, and you won't die when you get there, especially if you train properly. So how valuable is marathon running? Sorry to all my marathon runner people that listen to this. Feel free to, I climb Rocky Mountains. That's not real natural. It's a real incredible task to do. But, let's put it into nature. So anxiety will keep you alive, but slowly kill you off and make your life miserable. So there's a balancing act is how I find, I'm not wired that way, but if I was in nature, maybe that would be a problem. Oh, that's just a bear. Don't worry about it. I saw that bear before, taking it easy on the bear, might end up at the bottom of a messy pile there. So I think I think it's interesting to say, we have anxiety as a diagnosis, but we don't have. I just see it just seems so prevalent and almost like a crown of thorns sometimes. I just think people, maybe it's a little bit overdiagnosed, overused, but I like that you say it's valuable. So people aren't like, I have anxiety, isn't this terrible? No, you have anxiety and it might be for a good reason. Let's maybe figure out what that reason is so we can bring it down. Let's solve that question, like, what are you concerned about? Is everything's crazy, your whole life is really, so I think that's really, 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 really crucial, right? So I like I said before, I like your style. You are probably busy, I would think. Right? I mean, I looked up some stats about how many people need counseling and how many counselors there are, and it's not even close. So do you find your profession is in need of expansion? And if so, in what area? If somebody's interested in this, let's say they're watching this podcast and they think, I would love to talk to people about their issues, just like you discovered when you first decided to go in this direction. I thought that was cute. Now, I wish there was a job where I can talk. If someone's doing that right now, listening to you, they think, hey, I'm just like her. I want to do that. Where does a person start? And where's the void? Where is the need? That's the old key to success: find the need and fulfill it. Would they follow your path exactly, or was there a shorter route? Well, what would you do? What would you tell someone to do that says, hey, I want to do something like you do?
So there's definitely not one route. Definitely a bunch. And even so I went and got my master's in social work, which New York is kind of a social work state, is what I heard, when I chose, this or that. But you can go get your, counseling degree. You could, one of my friends is an LMFT, so marriage and family therapist. So there's a bunch of different type of mental health counseling degrees you can get, but you probably start with a master's degree. And then you definitely don't have to go get your doctorate like I did, but more than welcome to. I think it's great. And then, I would say all these states have, unfortunately, all have different requirements right now. But if we're just sticking with New York, pick a place to work for a few years, get your hours, get your client contact. And the thing I would really encourage people to do is figure out what population you really love working with, what diagnosis you love working with, what setting you like working with. So, some people love working with, prenatal stuff. Some people love, get a CASAC, so it's a special, kind of certification for substance use. I just happen to love complex trauma. And so I have taken a lot of different trainings, like specialized trainings, gotten certifications. I'm taking another training now. So you just dive into it. It's a profession. So I think, professional careers, you get to kind of figure out, I got to get my CEUs, right? So what am I interested? Let me like really explore this and take a curious approach to all of it. That would be my best advice if someone is interested. And, you could always, call like UB or something like that and say, hey, can you tell me about your program? There's absolutely people who'd be open to talking with you about that and kind of exploring, is this a good fit for you? The other thing that I 100% recommend anyone do if they're interested in this is go, get your own therapy. You will be a better therapist if you do that.
Yeah, we say that with chiropractors too. Like I love going for, there's 140 styles of chiropractic. I have not experienced them all because some of them are very hard to find because they're really strange and not too many people practice them. But if I ever have the opportunity at seminars, I try to talk a chiropractor into, hey, do that technique on me. That's pretty bizarre. And some of them are so subtle and some of them are so forceful. It's really funny to see the wide range of techniques because people need different technique styles. And then then sometimes, like you were talking about, feeling safe, even in a chiropractic office. I have a friend of mine, he's been on the podcast. If you haven't seen him, watch. It's Dr. Fred Clary. He's a chiropractor, neurologist, and a power lifter. He's about 320 pounds of he's like a door walking in the room. And he's a very gentle and kind person. He's very sensitive. He's extremely well read. Like I say, he's got a neurology diplomat, teaches neurology in schools, continuing education credits. But at first glance, he really looks like some kind of superhero that fell out of the sky that's going to like do something crazy. So there are patients that, look at him and go, there's no way he's working on me. There's no way. That man is too big. He twitches funny and he'll snap me in half. I can't do it. And then there's people that say, yeah, I need that guy because, if he's using 10% of his strength, he probably has great control, which is really the truth, and that kind of thing. So in your work, I think, too, it's a fit. You mentioned at the beginning of this podcast that you sort of like have a session to see if, if it's the right mix, if it's something that person has either personally that you think you can fix and the condition or the match. And I think I encourage people, if they've been to a therapist or a chiropractor, any professional, if it didn't work out, doesn't mean that whole profession's wrong for you. It means that individual maybe read you wrong or doesn't have the skill set for you. They're amazing at something else, but they're not amazing at you're at that thing. You mentioned the complex trauma, that's your thing. What isn't your thing? What is something that you think that person should go somewhere else? Is there anything you stay away from?
Yeah, I would say in general, some of the more like psychotic symptoms, I'm not a good fit for something like that. Definitely. And you might, go more inpatient, but then seek outpatient, sustaining treatment for something like that.
Okay.
I would not be a good fit for that. And I'm happy to treat anxiety, depression, but I feel like with there's a lot of other practitioners that also treat that. So, to make myself more available, sometimes I'll say, I do work with a specific niche. So, you need 4 weeks, you can absolutely do that, but you might be better suited to somebody who, you just want to kind of have more of a counseling relationship with versus more of a heavy therapeutic, let's dig into things. So I absolutely, I would never reject someone like that from my office at all. But sometimes people want something a little bit lighter, and that's fine too.
Uh-huh.
I will say too, I tend to be, sometimes I tell people like I am a fellow intellectualizer. So people who tend to over intellectualize or overanalyze, we can kind of get on the same level. And I'm like, I know you don't think feelings matter, and I said the same thing too, but they do. So let's start here. I understand you. And we tend to be a good fit.
Yeah, I can tell that about you. You have a depth in what you want to do. You want to get to the root of things. I think that's important. And for me, I have that with certain patients. Our conversations are always deep and complicated and confusing at times. I'm like, okay, that's amazing. I have a couple that I see, basic back and neck problems, but the conversation we get into, I always tell, especially her, they're a married couple. I tell her, I'm like, every time I leave this room, my head is literally smoking and I have to take a sip of something before I go in the room with the next patient I normally don't have to. I can fly from one patient to another and just be ready for anybody in the room. But coming out of that room, like, wow, she just reinvented what femininity means. Okay, I'm gonna have to digest this. I'm not ready to go in the next room yet. And yeah, for me, I'm similar to that. I like to have a good time and goof around with my patients and people in general. But I don't. I have never been in a conversation. I think this is getting too deep for me. I have to go home. The deeper and more personal it gets, I think it's more interesting. And that's actually why I have this one question for you, and it really fits because my last question that I have in my head for you is a silly question, and I think sometimes silly questions can get you to think, and you can turn it into something pretty deep. Many of us long to be better at what we do in general, to the point where we wish we were super powered. So I love asking people a few questions like, what's your favorite color is one of my favorite questions because it's so silly, but you really get some interesting answers. Mickey Rourke was someone who I'm always, if you know who that is, he's kind of an older actor. He's been known for having multiple. Now there's a man with complex trauma. If you listen to interviews with him, wow, brutal life. And they asked him one time, what's his favorite color? And he's such kind of a macho guy and, Hollywood actor. And then he was a boxer, then went back to acting. He said, the last color a woman told me I look good in, which is such a, exactly. It's such a macho, sexy answer that I was like, wow, that's why he's Mickey Rourke and I'm not. But if you had a superpower, if you were given one, what would it be?
So it's going to sound so like, but like truly if I could like just put my hands over someone and just like heal them. I've thought about that so much. Like I wish I could just do that. And yet, I know that I would then also be kind of robbing them of the experience of having said, I did this. I mean, it's like I fix people. I am with them on their path, but they do that. I take no credit. I will help, I will guide, but you did that, and you get to take that with you, that you now can trust yourself for the rest of your life. That like it's just so empowering, and I would not want to rob that. So I don't know.
Absolutely. Fantastic answer, and so true. The reason why, in my opinion, we don't have superpowers is because they would do just that. They would take away someone's ability and change how we are supposed to get from point A to point B. I think that is the kind of answer I'd expect from the little that I know you now, because it's that's deep and it's very real. I don't think anybody really should be walking around with this idea that they are the science, or they are this, or they are that. An old time practitioner one time told me, when someone comes to you and tells you as a chiropractor, what you just did was unbelievable, I can walk now, and they look at you like you're a god, don't believe you're a god. And when someone tells you the last adjustment really hurt and you made me worse and I don't like chiropractic and I don't think I'm coming back and I don't know what's wrong with you, don't think you're a bum. You didn't invent chiropractic. You're just doing your best at it, and learn both. Each should be a learning experience. Anytime someone talks to me in either of those fashions, I correct them and say, okay, your body healed, I directed it, it was ready, and I'm good enough to foster that reaction, but I'm not any better than that. Your body had to do it. And if someone thinks, okay, that last adjustment wasn't great, Noel, your body is that stiff, your diet is that bad potentially, or your body isn't ready to heal because of, now I can say, complex trauma to them, because of the amount of emotional tension in your body, was how I would normally say it, right? And I'd still want to encourage them to continue with me, and I would maybe change technique styles, go a little slower, because that's maybe I demanded too much out of a body that wasn't ready to go from point A to point B. I've maybe tried to bring it to point C, because people are a bit impatient, as well as I can be, to try to get somebody to feel better in the limited time that we sometimes have with our clientele. So, well, Dr. Kelsey Bennett, thank you for coming on my show. I appreciate it. Very enlightening. I appreciate all that you've had to offer today. I would love to. I'm going to probably send you a lot of people. Hopefully, you have some space for them.
Absolutely.
Because as we're talking, my patients over the years, a lot of them just keep popping in my head that I think would match you perfectly. And I'm glad that you're doing what you're doing. You're passionate about what you're doing. Congratulations on becoming a doctor. Like you said, that wasn't necessary, but it's such a, I think having credentials for some of your clientele is important. When people find out that my education parallels and often exceeds that of a medical doctor, that they like that. I don't tell them that. They tend to, well, I probably haven't. It's not that I never told anybody that, I must admit, but I don't say it a lot. But people will ask, and sometimes they'll look it up, and that helps people say, okay, this person tried hard, at least, so went to school a long time, read a lot of material. And I think that what people want is that you care and that you try hard and that you're there for them. And it means something to be good at what you do. And I think education is one of those things. For all the times that we talk about student debt relief right now in the news, and at the same time, many people not even promoting going to college. There's, pretty wealthy people that have run this world that are like, college is fun, but you don't need it. Ignorance isn't the answer to anything, in my opinion. And I don't say that about a lot of things, but knowing things, reading things, and, looking at, does it fit you? Does it make sense? And keep going, keep reading. I think half the problems in this world are because people don't read books. You buy a book and read it, for God's sakes. I don't know what's wrong with people, right? It's not all about 30 seconds of a news clip, right? It's going to be spend a few days reading a couple of good books. Well, thanks again for coming on. We'll talk soon, and maybe we'll have you on the show again. I'll dream up some other crazy questions for you, and we'll have a good time. Okay?
Sounds good. Thank you so much for having me.
Thanks, Doc. I appreciate it. Thank you.